allo transplant is really the only curative modality for patients with accelerated blast phase disease. We also know that some degree of disease control is essential for patients to have durable outcomes post-transplant. In the accelerated phase, there are data to support taking patients directly to transplant without blast reduction. So a study led by our European colleagues looked at these patients specifically and found a 3-year overall survival of about 65% for patients in accelerated phase that go directly to transplant without blast reduction. Now, in blast phase, greater than or equal to 20% blasts, in general, our paradigm is to try and reduce the blast percentage at least down below 10% and perhaps even down below 5%. The major issue has been is when we look at the outcomes of patients post-transplant, it does not seem that blast reduction is a great proxy for who has cure with transplant and who relapses post-transplant. So in my mind, when thinking about transplant eligibility, of course, age, fitness, other medical comorbidities, just thinking about is someone an appropriate candidate for transplant in general. And then when thinking about disease-specific factors, in my mind, the big thing is trying to have the disease more approximate a chronic phase of disease. So ideally trying to get that blast percentage down below 10%. We don't know if trying to really strive for less than 5% is all that beneficial. We do know that if we're taking patients to transplant with 20, 25, 30% blast, it's very, very likely that they're going to have an early relapse post-transplant.